Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our lecture today about intrapartum fetal assessment. So, what we are going to discuss? The aim of intrapartum fetal assessment and the methods, and we have 4 methods available for fetal assessment during labor. The biophysical profile, the fetal heart rate monitoring, the fetal scalp pH, the fetal pulse oximetry. This is our target in this lecture. So, what is the aim of intrapartum fetal assessment? Really, intrapartum fetal assessment are performed to assess fetal well-being during labor. So, this is the 4 items included under the heading Methods of Intrapartum Fetal Assessment. The biophysical profile, and this is explained in details in the previous lecture. The fetal heart rate monitoring, either interrupted monitoring using handheld Doppler or continuous monitoring using cardiotocography, the CTG, or fetal scalp pH to detect the fetal acidosis, and lastly the fetal pulse oximetry. Let us start with the biophysical profile. As we said before in the previous lecture, it is a 30-minute long ultrasound assessment to assess fetal well-being coupled with fetal heart rate tracing. So we have a score of 10 and 5 items. Each one has 2 in score if it is positive or reactive. Okay? The non-stress test, reactive if 2 fetal heart rate acceleration in response to movement, amniotic fluid volume, a single deepest vertical pocket of amniotic fluid greater than 2 cm and less than 8 cm, fetal breathing movement, 1 or more rhythmic breathing episodes of 30 seconds or more, fetal movement, 3 or more fetal gross body movement, separate movement of the body or limbs, fetal muscle tone, 1 or more opening or closing of the hands and the mouth, extension and deflection of the limbs. So the result of the score, either 8 or 10, is reassuring or normal. If the result is 6, this is equivocal. If the result is 2 or 4, this is non-reassuring and we should expedite the birth. If the result is 0, this means the baby has an asphyxia and emergency cesarean section should be done. The second item in intrapartum fetal monitoring is the intrapartum fetal assessment. The fetal heart rate monitoring. And as you see in the picture, this is the handheld Doppler, what's called sonicate. This is a monitor. This is the fetal heart rate. This is a probe with using gel is applied to the abdomen of the woman at the maximum site in which the fetal heart sound can be clear. Okay? And The second one here, second picture here, is the CTG, the cardiotocography. The cardiotocography, as you see in the picture, there is two transducer, one, the lower one for the fetal heart rate assessment, and the upper one on the fundus of the uterus for detection of the uterine contraction. And both of them connected to this monitor, and this the printed strip of paper containing both the number of contraction per 10 minutes and the fetal heart rate tracing. Okay, so if you are going to do intermittent auscultation, you can use handheld Doppler. If you are going to do monitoring in a continuous manner, use CTG. Okay, let us talk about the structured intermittent auscultation. It is a technique that employs systematic use of Doppler assessment of the fetal heart rate during labor at defined timed interval. So, what is the time interval to measure the fetal heart rate using the handheld Doppler ultrasound? Every 15 to 30 minutes in the active phase of the first stage of labor, and every 5 minutes in second stage of labor. Okay? What is the procedure of intermittent auscultation? First, you should do the obstetric grips to know the position of the fetus, where is the back of the fetus, and to know which is the maximum point you can apply the probe of the handheld Doppler on the abdomen. Okay? Then differentiate between maternal pulse from fetal pulse. Please try to palpate the maternal pulse while you are doing auscultation of the fetal heart sound with handheld Doppler. Okay? Palpate for uterine contraction during fetal heart rate auscultation to determine the relationship, if there is change in the fetal heart rate during contraction or not. And please count the fetal heart rate between contraction for more than 60 seconds to determine the average baseline rate. And also, please count the fetal heart rate after uterine contraction for 60 seconds to identify fetal response to active labor. Because you can detect delayed deceleration while you are counting the fetal heart rate after uterine contraction, because late deceleration continue after the end of contraction. But early deceleration, which is descent of the fetal heart rate, as we will see later on, occur with the early deceleration. The drop of fetal heart rate occur with the start of the contraction and the end with the end of contraction. But late deceleration, the drop in the fetal heart rate continue after the end of contraction. That's why you should count the fetal heart rate after uterine contraction for 60 seconds. Okay, let us go to the continuous electronic fetal monitoring, what's called CTG or cardiotocography, which is a technical method used during pregnancy to monitor the fetal heart rate and uterine contractions. It is used to monitor fetal well-being and to allow early detection of the fetal distress. What is the indication? It should be used when there are abnormalities in the structured intermittent auscultation or for high-risk patients during labor. Okay? High-risk pregnancy may be due to maternal factor or obstetric complications as seen in this table, like maternal factors like hypertension, diabetes, smoking, bronchial asthma, drug abuse, obstetric complication like IUGR, premature rupture of membrane, post-date gestation, multiple pregnancy, oxytocin induction use, previous cesarean section, preeclampsia, congenital malformation, all these are high-risk pregnancy. What is the procedure of CTG? We are placing two transducers, as in this picture, onto the abdomen. One transducer records the fetal heart rate using Doppler ultrasound. This is the lower one in the picture. And the other transducer, the upper one, over the fundus of the uterus, monitor the contraction of the uterus by measuring the tension of the maternal abdominal wall. Lastly, the CTG should be assessed by the obstetric medical team. What is the interpretation of CTG or how to read CTG? First, define the risk. Is your patient high or low risk? Because the decision at the end of the CTG also depends on if the patient is high risk or not. Then the number of contractions per 10 minutes. This is the second item. As seen in the picture, this is the strip of paper of CTG resulted. The vertical axis for fetal heart rate per minute, the horizontal one for the time per minute. Each big square is 1 minute. So the second item here is contraction. How many contractions per 10 minutes? As you see in this picture, this is 1, 2, 3, 3 contractions per 10 minutes. Okay? Okay. Then the next item is baseline fetal heart rate. How to know the basal fetal heart rate? Please look to the upper red heart rate tracing on the paper. It is in red in color here. The baseline here is about 130 nearly, okay? Please avoid any acceleration and any deceleration. Take the baseline, okay, in the last 10 minutes. This is the fetal heart rate. Then the variability. What is meant by variability? The difference between one beat to the other, okay? The variability is important to give you an impression about the neurological system of the baby. Is it healthy or not? So the variability is something important from beat to beat, as in this one. And the normal shouldn't exceed 25 and shouldn't be less than 5. So it is between 5 to 25 beat per minute. So if you look here, you can see from one beat to the other, it is between 150 to 130, for example. So it is in the normal range. Okay, this is called beat to beat variability. Should be ranging between 5 to 25 beat per minute. Okay. Then go to the next item, which is acceleration. Acceleration means abrupt increase in fetal heart rate equal to 15 beat per minute or more, lasting for more than 15 seconds or equal to 15 seconds. Okay, as in this is acceleration. This one acceleration, this one acceleration, this one acceleration. So more than 15 beat per minute. Okay? Okay. Or equal to 15 beat. Okay? This is called acceleration, and this is a good sign, reassuring sign that the fetal health is good. But its absence in CTG doesn't denote that the baby at risk. So its presence give you good impression about the fetal health, but its absence doesn't mean the fetus at risk. Then go to deceleration. What is deceleration? Abrupt decrease in fetal heart rate equal to or less than 50 or more than 15 beat per minute. So there is drop of the fetal heart rate suddenly 15 beat or more, lasting 15 seconds or more. Okay, this is called deceleration, as you see in this picture. This is deceleration. And the deceleration could be early deceleration, variable deceleration, late deceleration. Okay? Okay. So, what is the difference? Late deceleration denoting fetal hypoxia and fetal distress, while early deceleration could be physiological. Explain more, please. During uterine contraction, if there is drop in the fetal heart rate with the contraction and the end with the end of the contraction, this is called early deceleration. Okay? But if it continue after the end of the contraction, it's called the late deceleration. And this is dangerous, denoting the fetal hypoxia. Okay? And denoting that there is deficient placental perfusion. While the early deceleration could be physiological due to increased intracranial tension and the increased vagal tone, leading to this bradycardia and the drop in the fetal heart rate during contraction, and resolve completely with the end of the contraction. So early deceleration is physiological, late deceleration is pathological. Also, prolonged deceleration is pathological if it lasts 3 minutes, and it is non-reassuring if lasting 1 minute. Okay. What about the variable deceleration? Variable deceleration can occur physiological during labor due to cord compression, but could be pathological if there is variable deceleration. It may happen at any time, not related to contraction. It may be repeated all over the CTG evaluation. The variable deceleration of concerning characteristic is risky, is dangerous one. If there is deceleration without shouldering, if there is W-shaped deceleration, if there is deceleration and not reaching the basal fetal heart rate, okay, if there is prolonged deceleration, if there is absent beat-to-beat variability during deceleration. By the way, one of the ominous signs in CTG is the sinusoid pattern. There is no beat-to-beat variability like this one, just waves, 2 to 5 cycles per minute, and this is very dangerous sign, but may happen in a physiological case, like some suckling. But if you did follow up to the CTG, you will find it resolved completely suddenly. Okay? So this is called, this ominous sign with absent beat-to-beat variability is called sinusitis pattern. Okay? Lastly, after you finish the CTG, you should announce and you should give an overall impression. Is it reassuring or non-reassuring or abnormal? According to what? According to the fetal heart rate, is it more than 180 or less than 100? This is an abnormal. If it is non-reassuring, it will be between 160 and 180 or between 100 and 110. This is called non-reassuring. Okay? The normal between 110 and 160. So, severe bradycardia less than 100 or severe tachycardia more than 180 is considered abnormal. Absent beat-to-beat variability. This beat-to-beat variability is absent or decreased, is non-reassuring or abnormal one. The sinusoidal pattern with absent beat-to-beat variability is abnormal and a very dangerous one. The variable deceleration with concerning characteristics is an abnormal one. The late deceleration, repeated late deceleration for more than 25 minutes, this is also a dangerous sign. So, at the end of the CTG, you should say, is it normal or non-reassuring or abnormal? Then the intervention is going on. Okay, this is what I said before. First, define the risk, high risk or low risk patient, contraction, the number of contraction per 10 minutes, as in this picture. Then detect the baseline fetal heart rate, avoid the acceleration and deceleration, take the baseline. The variability from 1 beat to 1 beat, and as I said before, it is 5 to 25 beat per minute from one beat to the other. What are the causes of reduced variability? Fetal sleeping is the commonest cause. This is physiological, and you can find the answer if you continue monitoring. It will disappear, and you can see the CTG becomes normal with beat to beat variability with the normal range. Okay, or with the stimulation of the baby. Fetal acidosis is an important cause of reduced variability. Fetal tachycardia, drugs like opiates, methyl dopa, benzodiazepine, magnesium sulfate, also in premature baby and congenital heart abnormalities. As you see in this picture, on the right side reduced variability, and on the left side this is the sinusoidal pattern, which is very dangerous. Okay, that the fetus at rest. This is the acceleration, the other item, abrupt increase in fetal heart rate greater than or equal to 15 beat per minute for 15 seconds or more. Deceleration, as I mentioned before, look to this one. This is the early deceleration that drop the maximum with the maximum contraction and disappear with the end of contraction. But here it started during contraction and the end beyond the relief of contraction continue till it is relieved. So this is called late deceleration, and the late deceleration is a dangerous sign of fetal hypoxia, also the variable deceleration of concerning characteristics. Then we reached the overall impression, reassuring, non-reassuring, or abnormal, as I mentioned before, depending on the baseline heart rate and the variability and the deceleration, as I mentioned. What is your intervention for abnormal CTG during labor? First, change the maternal position. Then do follow up. Is it the condition improving or not in CTG? Assess maternal vital signs, temperature, blood pressure, pulse. Discontinue oxytocin infusion if in use. Initiate oxygen to the mother by mask. Perform a vaginal examination. Why? To check for cord prolapse, rapid descent of the head, or vaginal bleeding suggestive of placental abruption. Give intravenous fluid if not already administered. Assess fetal pH, scalp pH. Fetal scalp stimulation or acoustic stimulation. Give amnio infusion for recurrent, moderate to severe variable deceleration. Consider need for expedited delivery, either operative vaginal delivery or cesarean delivery, according to the situation. Okay, so till now we finished 2 items in intrapartum fetal assessment. The first one, the biophysical profile. The second one, the continuous fetal heart rate monitoring using CTG. Okay. And we said we have 2 methods for fetal heart monitoring: the structured interrupted one using handheld Doppler, and the continuous fetal heart monitoring using CTG. And we said how to read the CTG and your interpretation, and what is your overall impression at the end and your intervention. Now we are going to the third item during intrapartum fetal assessment, the fetal scalp pH, and I have a previous lecture with details about fetal scalp pH. So I'll summarize only few points. What's your aim of fetal scalp blood sampling? Blood sample is taken from the fetal scalp for pH and the lactate measurements. In case of fetal heart rate at risk of acidosis. Okay, so the result of the CTG suggesting fetal hypoxia and acidosis, you want to confirm, you are going to do fetal scalp pH, and you will measure the pH and the lactate. What's your interpretation for results? What is the normal for pH? Should be more than 7.25. Pre-acidosis pH between 7.20 and the acidosis about 7.25. Okay, sorry, acidosis less than 7.20, but the pre-acidosis between 7.20 and 7.25. So the normal in pH, fetal scalp pH, should be more than 7.25. What about lactates? Normal lactates less than 4.2 millimole per liter, while the pre-acidosis ranging between 4.2 and 4.8 millimole per liter. and the acidosis is considered if lactates more than 4.8 millimole per liter. Okay? So, what is your action after you know the result? If the fetal blood sampling is abnormal, inform senior obstetrician, midwifery coordinator, and the neonatal team. Talk to the woman and her support person about the result of the fetal blood sampling and expedite the birth because you are in an emergency situation. If the fetal blood sampling is borderline, consider repeating the fetal blood sampling within 30 minutes if it's still indicated by CTG trace. What if the fetal blood sampling is normal? It's okay, no problem. Continue monitoring with CTG. But if ongoing CTG concerns, repeat fetal blood sampling within 1 hour. Okay, we finished now 3 items: the biophysical profile, the intrapartum fetal heart rate monitoring with CTG, then the fetal scalp pH, and lastly, we have the fetal pulse oximetry. Actually, fetal pulse oximetry depends on that the fetal oxygen saturation is a more suitable measure of fetal distress. I want to know that if the baby hypoxic or not, so fetal pulse oximetry is a good choice. It looks like that. But the problem is how to reach the baby. How to reach the baby to measure the fetal oxygen saturation. Yes, you can apply the fetal pulse oximetry during vaginal examination on the fetal head, in the top part of the fetal head, okay, to find if the baby hypoxic or not. Or recently there is transabdominal fetal pulse oximetry to be non-invasive and easier, but under research trials. Okay, the fetal pulse oximetry aims aims to improve the accuracy of the evaluation of the fetal well-being during labor. But really, it was found in many studies, many researchers, that fetal pulse oximetry doesn't decrease the rate of cesarean section in cases under CTG monitoring. So it has no advantage as regard it doesn't reduce the number of cesarean section. Some advise that fetal pulse oximetry can be used as adjunct to CTG but not replacing CTG. Okay, you can add it for patient at rest if there is concerning signs on CTG. You can do fetal pulse oximetry, and according to the result, your intervention will be. This is the end of my lecture. This is my 4 books published on Amazon, and this is my site on Amazon. Thank you, everybody.